Good afternoon, ladies and gentlemen. For the gentlemen here, a happy Father's Day. It's an impressive turnout. So many fathers here away from their homes. More surprising, so many prospective fathers also here. So that tells us the credibility of the team which is organized it. You are ready to sacrifice your post-lunch siesta or any other activity for your learning. I happen to work with this team for several years and I am here, and whatever I present before you is learnt during that time. All of us are aware that there is something called as biomarkers on the horizon. We have been hearing this probably from last 10 years or so. But the question is, are we there? Are they actually useful? There is a recent editorial which talks of renal biomarkers. Have they failed us? But the part of the heading is a big no. So there is some more knowledge that all of us need to have to be able to use it routinely in our day-to-day practice. You must have seen this any number of times, which talks of the conceptual model for AKI. We actually pick up AKI presently when there is established kidney failure, almost just one step or so before very poor outcomes are encountered. What we should be doing actually is to pick it up very early, and in spite of the recent consensus on a uniform definition across the world after 2002, 2005 ADQI and Akin definitions, we know that the two values that we use, serum creatinine and urine output, both of them are not very reliable in an acute situation. The reason being, the simple cartoon tells us when GFR drops from 120 to 70, there is a rise of creatinine only from 1 to 1.5. So if you keep looking at it, even by the present CKD epi formula that you use, every 1 milligram drop or a rise will change almost 40% to 50% of the GFR in the early stages. Whereas in late stages, even a small change will not affect the serum creatinine much. So this understanding clearly tells us that when you are following a course of AKI, there are so many other factors which look at the urine output and the creatinine, the generation, the volume of distribution, tubular secretion continuing though the GFR has fallen, and you cannot determine your interventions based on an unreliable marker. This probably explains, in spite of the fact that the world is comfortable now using a uniform definition across the world, whereas even 5 or 8 years back that was not so. Published in 2004, we had 33 definitions accepted in the literature. So even after Akin and Rifle came up, and we know that these criteria actually have an effect on mortality, irrespective of why the patient got into the hospital. Patient have got into the hospital for an obstetric cause, patient might have got into the hospital for an orthopedic cause, but once the renal failure sets in, the outcomes are uniformly very, very poor. So much so in the last 50 or 60 years, we have not achieved an improvement in the mortality after AKI sets in as a part of multi-organ failure. So there is robust data which said that each of these parameters, if you take oliguria for example, is a predictor of mortality. Both the number of hours of oliguria, these are randomized studies done, both the number of hours of oliguria and the episodes of oliguria, both of them actually affect your outcomes. Therefore, it could be a very early marker for you to say that this patient needs to be treated differently in your ICU. We also know now that a single episode of AKI, this is actually data from a post-contrast study, you follow up those who had a AKI and those who did not have a AKI. Even 2 years after the single episode, patients behave differently. They come back to hospital more often, they have more septic episodes, they die more often. A single episode changes their protoplasm significantly. Again, a new knowledge in the last probably 5 or 7 years. This is now accepted by International Society of Nephrology as the natural history of AKI. Hardly any AKI actually fully recovers. Most AKI gets into a mode of CKD, and this cohort of patients who get into CKD are more prone for repeated episodes of AKI. And there is a group which have a single or two episodes and then go into end stage very, very fast. So we know a little more about why AKI leads to CKD. You don't need any other reason for a person to get into CKD. So among the list of causes in any country now, for example, in our country we have 7 causes which cause 97% of CKD. We have to add to that AKI as one of the causes of CKD. The model that is accepted today is you have an insult, there is a drop in GFR, there could be a repair and recovery, but most often there is a chronic element, second episode, third episode, which takes these patients faster to ESRD. Very clearly there are mechanisms now elucidated and accepted both in the lab and in the animal studies and in the humans, wherein the damage, inflammation, repair is always not the case. In fact, most often it is damage, inflammation, repair and fibrosis which sets into chronic kidney disease. So this studies led to a lot of understanding. You have a normal epithelium in the tubule, you have a functional impairment and damage. A lot of things happen during this time, and there is elaboration of certain metabolites, proteins, RNA, DNA, which are released into serum and into the urine. So that brought into what could be the future. You have not yet achieved, though you got a uniform definition and a little earlier diagnosis than what you did 10 years ago, but it has not translated into outcomes. So will it happen? Will biomarkers change the diagnosis and staging criteria? Will the gap between these AKI CKD definitions be addressed, and is there a harmonization of these settings? So there is a lot that happened. This was the 10th ADQI, and because I was working with the good critical care team, I was part of this as one of the faculty. There were 6 papers which came out of this 10th ADQI consensus conference on biomarkers. This was in Kidney International, which talked of the summary of the recommendations. And this was how to use biomarkers, and this was published in Contributions to Nephrology, to assess prognosis and guide management of patients. So most of the data I am going to talk to you comes from these papers. Anyone of you want soft copies of this, I will send them to you. So what is the definition of an ideal biomarker? It has to be highly sensitive or highly specific. It has to reflect the abnormal physiology. Prognosis must be meaningful and clinically actionable. You should look at the biomarker level and say this needs to be done, and it should be used as a basis for specific biomarker guided therapy. Either you start dialysis or you do a particular treatment based on that. So what should be the characteristics? It should be non-invasive, easily measured, inexpensive, and it should provide rapid results. So most of these should be point of care. You can't have a sample sent to the lab and you get it in the evening, then the entire argument of picking it up early does not hold any water. So these are the list of things that are identified which should be an ideal biomarker. So what is the present understanding? There are several biomarkers patented by different individuals. Many of them happen to be Indians. NGAL, for example, Prasad Devarajan has a patent on it. Interleukin 18, Chirag Parikh has a patent on it. So all these things are validated in the lab. Subsequently, they have done several studies validating them in the hospital setting. And there is data, some of which we will discuss. My own understanding is, in future, you are going to get to a situation wherein you will not use a biomarker. You are going to use a combination of biomarkers, because we know very well each one of them starts at a particular time. There are biomarkers which are elaborated by 2nd hour after the insult, 4th hour after the insult, and then you know how they increase and decrease. You are likely to see in a patient something like this when you have a panel of renal biomarkers. So just like you use your liver function test today, it's not a single one. We are used to liver function test means we go through albumin, total protein, SGOT, SGPT, all of them, Similarly, when we ask for a renal biomarker panel, you are going to at least do 3 or 4 of them, which is going to tell you a couple of things which is quite interesting. We know these biomarkers are elaborated from a segment of the tubule. So we also know what happens to them time wise, when they get rise, when they get a fall. We also know exactly the mechanism by which they are coming into the urine or they are coming into the blood. So appearance of the biomarker in the urine or in the blood, time and also the location. It is going to be which biomarker, how much is going to tell you what insult, whether it is a ischemic insult or a toxic insult, where in the tubule. It could even tell you proximal, loop or distal. It also may tell you details of which part of the cell that it is coming from. And when you use them as a combination, you are there that you know the severity, you know the location and you know the type of insult. So this is reality as of today, it is possible. So what is that we have not yet achieved to fill the gap? We have to learn to use these biomarkers as a group and then say probably it makes sense not after the GFR has fallen even to pick up a patient at risk. So your patient gets into ER, you send a biomarker. Patient gets into the ICU, you send a biomarker. You know which of these patients after a couple of days is likely to get into trouble. That is what will be the most benefit. So we need them to risk assess, recognize the AKI, differential diagnosis, just like you do a TROP-I and say this is not ischemic coronary artery disease. You need for renal also. Then it should guide you targeted intervention and also tell you prognosis. And there is data which now talks of when you use in combination your rifle or akin or KDIGO definition of AKI, which takes into account creatinine and urine output. Superimpose a biomarker on that. You move away to the left side of the conceptual model and pick up when there is an increased risk and where is a very early damage to the kidney. So your future practice is going to be on one side you have the functional criteria. So you look at the GFR or serum creatinine or urine output, which are the functional criteria. They increase or they change only when the function of the kidney is already dropped. But you superimpose that with a biomarker which is not a functional criteria, it is a damage criteria. It goes up much earlier, sometimes 70 to 96 hours earlier than the functional biomarker. Use them as a single definition. We need a definition which includes both of them and it is likely to be something like this. You have on one side the urine output and creatinine criteria and on the other side the level of rise of the biomarker. The second thing that is going to be important is a large cohort of your patients in the ICUs already have established CKD which you are not aware of, but the biomarker is likely to tell you this patient has existing CKD. It always need not be a serum creatinine. We know now the cutoffs for NGAL in CKD. Similarly, there are many biomarkers which tell you this level is in CKD. So you pick up a normal kidney, you get an abnormal kidney, and as you know the prognosis, severity, the dependence on RRT, recovery, all of them are dictated by whether the patient has a pre-existing CKD or not. That also becomes possible. What we have not achieved is we know the biomarkers, we know the level which is called as a laboratory cutoff. Lab says this level is the cutoff. Clinically, there is data now to support at least some of these biomarkers. When they are 10 times more, they are clinically actionable. But there is a gap between the laboratory cutoff and the clinical cutoff. And that is supposed to be the gray zone which we don't know how to fill it. Most of our knowledge in this gray zone is what needs to be, or the experience needs to be more. And we know when the level is here, what do we do? So the concept of negative predictive value is very good below the lab cutoff. Positive predictive value is very good after the clinical cutoff. In between, what do? You just have the value and you wait, and most of our patients probably will fall in that area. So this is data on 15 different authors pooled data on cardiorenal syndrome, wherein the authors proved that when you use creatinine alone, when you use NGAL alone, and when you use both as a combination, what happens to the predictability of RRT initiation, in-hospital mortality and outcomes. They were extremely good and statistically significant when you use the same table which I told you, both in both the functional markers and the damage markers. When you use them together, you could predict all these outcomes. And there is significant valid data available in these settings on a combination of biomarker along with your functional markers. Cardiac surgery, intensive care, contrast-induced, drug-induced nephrotoxicity, CKD as I already mentioned, and even glomerular disease acute. There is data available that biomarkers help when they are used along with functional markers. This is again from the same papers wherein all these different biomarkers used in more than one setting could predict RRT, could predict death, could predict AKI going into CKD, and also could predict how many days are the prolonged stay in the ICU. So the question is, what do you do when you have a biomarker? So at least the present data suggests that it helps you to triage the patients. You have a biomarker in the ER, you can decide based on the biomarker. I am sure most of you are aware of the GALAN trial, the primary investigator being Alan Meisel. In GALAN trial, NGAL was more predictive of cardiac mortality than TROP-I was, than BNP was. Because once the kidney is significantly affected, the mortality gets dictated by the severity of the kidney disease. So you can triage based on the level of the renal biomarker. You can take an early consult, whether this August gathering believes or not, there is data to support a nephrology consult early in the ICU, the outcomes are better. Question is, what does the nephrologist do? Hardly anything. So there is a list of things now, most of them talking of renoprotective strategies, differential diagnosis, not doing further damage. Simple thing, stop ACE inhibitors and ARBs. 2 days before the patient goes for a surgery, the incidence of AKI comes down. The same drug which is renoprotective in the long run can make the patient more prone for an acute insult because it doesn't allow the compensation when there is a hemodynamic insult. So I will not go into the details of these, but as I told, you are going to see a new diagnostic criteria wherein there is a biomarker positive or negative or how severe it is. And once you have this in place, you will have 4 groups of patients. First group wherein there is no change in the damage marker, there is no rise in biomarker, there is no change in the functional marker, creatinine or urine output. This is a normal patient. The second group, you have a functional change, creatinine is up, but the damage marker is not up. Obviously, this is a pre-renal patient. Many times the doubt that you have, is this patient pre-renal or not, will be addressed by this. You give them more fluid. Third group, your damage marker is high, but your function is not yet deteriorated. So your creatinine is normal, and this is probably the biggest cohort of patients where we will benefit using biomarkers, because you pick them up very early, stop further insults, and do whatever is necessary. The fourth category, where your damage marker is high and the functional marker is high, they are the ones who will need very early RRT, because there is established damage which is still sustained and your function has already come down. So this is again one of the papers from Contributions to Nephrology from EDQA 10. I would suggest all of us who want to use biomarkers to go through this. The last part of the talk I just want to mention, after enough robust data regarding NGAL, KIM1, LFAB, interleukin 18, 2014 the discovery study brought out 2 more biomarkers. One, TIM, that is tissue inhibitor of metalloproteinase 2, and the other one IGF-B7, insulin binding protein 7. So both of them in discovery study and Sapphire study, which were done to pick up which was the best biomarker among all the renal biomarkers, stood out as the most promising, and the only biomarkers approved for clinical use in US today are TIM and IGF-B7. Both of them are used as a urinary product Subsequently, after the discovery and Sapphire study, which said these are the best biomarkers, two more papers or two more studies, Opal and Topaz, proved that there is a cutoff of 0.3 which was relevant to the clinical outcomes of these urinary biomarkers. So they actually are, when there is an injury to the kidney, they are elaborated from the cell as the cell goes into what is known as a G1 cell arrest, and they are extremely useful day to day, and compared to the limitations of the conventional biomarkers, using them along with your functional criteria will help you to achieve good clinical outcomes. Again, to stress, there is enough data to at least couple of them, NGAL, KIM and interleukin 18, when they are used in combination, there is a good outcomes or good predictability of the outcomes. The last part I wanted to cover our own data on biomarkers. We had some data both in two cohorts. One was NGAL in coronary angio group and the other was in CABG group, and we found them very useful. Details of this data we can discuss another time. I just completed my time period. Thank you very much.